Good morning or afternoon, depending on where you are. My name is Bethany Boschert, and I am the Marketing Operations Associate. We are the Digital Health Hub Foundation, a digital health accelerator at the Worldwide Center for Healthcare Innovation. Our largest program is our awards program, which seeks to find the next best, most impactful, and disruptive in 13 different categories. Let's move this along. We have had over 1,500 companies apply this year. 350 were named quarterfinalists, and now we have our 127 finalist companies. We are here with our 4 best-in-class finalist companies. Congratulations to you guys. And now I would like to introduce Dr. Daniel Kraft, founder and chairman of NextMed and Digital.Health, and co-executive producer of the Digital Health Foundation and Digital Health Awards. And here we go.
Thanks so much. Great to be with you all. We've got both the best-in-class and rising star companies. So we have 12 amazing finalists in this category, which is focused on health equity. I'm Dr. Daniel Kraft. I'm a physician scientist type. I'm the founder of Digital.Health, which is a platform where you can find, discover, start to prescribe and learn about all these amazing digital health companies and solutions, and also chair a program called NextMed Health, where we look at the future of healthcare. And lucky to be a co-executive producer here for the Digital Health Awards for, I think, the 3rd year. And really excited for this category. We're going to be learning a lot about 12 amazing companies and what they're doing in health equity. Before I do that, I think I'm passing off the baton from one of our colleagues from McKinsey to share a little bit about what they're seeing across the innovation space here. And if they're not here, I'll speak to their slide.
I'm here. Can you hear me?
Perfect. Tamara,
Yeah.
take it away.
Nice to meet you. So
forward the slide over.
Thank you for having me on as a knowledge partner today. My name is Tamara Baer, and I'm an associate partner at McKinsey and a pediatrician, and I lead our work on social drivers of health and health equity, including innovative collaborations with startups. And I'm really excited to be part of this group and hear about all of these health equity startup companies. So sharing some brief perspectives based on our work with over 1,000 startups and scale-ups globally, including 250 unicorns, and many long-term healthcare partnerships to accelerate growth and valuations. From this experience, we have learned that the 10 timeless tests of strategy can help test the strength of startup strategies. So there are 6 of these highlighted for you to consider. This is for the judges. So to give you a flavor, the first test, will it beat the market, aims to identify how your strategy is different and better to avoid the pitfall of just playing along with market forces. The second is around what is the special sauce of the specific special capability that is critical to your company's success. The third is about where, not how, you are competing. So our research has shown that 80% of the variation in revenue growth across companies is explained by choices about where to compete, and the remaining 20% explained by how to compete. So as you evaluate strategies today, we encourage you to ask yourselves, how many tests does this strategy pass? With that, good luck to all of the CEOs, and we're grateful for your passion and dedication to improve healthcare. So I'll hand it back to Dr. Kraft and Dr. Sarkar now. Thank you.
Great. Thanks, Tamara. I'm also a fellow pediatrician, medicine and pediatrics. And I think whatever healthcare field you're in, it's exciting to see innovations across digital health and that apply to improving health access and equity. I think most of these companies are not quote unquote health equity companies per se, but are applying their solutions to improve equity and access around the planet. And so we're excited to hear from them. And I want to see if my collaborator from UCSF is here. I believe she is. Dr. Sarkar, you want to say a quick hello and introduce yourself?
My name is Urmimala Sarkar. I'm a professor of medicine here at UCSF, and I run an initiative called Solve, which is to support companies in the digital health private sector to do health equity better and to understand the effectiveness of their solutions. I'm really honored to be here. Please forgive me that I'm going to be mostly on audio. I just have an unpredicted hiccup in my day today, so really sorry about that. But I will be here. I'm going to mute myself and stop my video, but I will be listening intently.
Great. Thanks for joining us. All right. Well, let's get started. So for the Digital Health Awards this year, they're characterized as best in class, which are more advanced companies, have raised over a certain amount of funding, have been around for a certain amount of time, and rising stars, sort of newer companies earlier in their journey. And we're going to hear from each of them. And I'm going to ask each company to sort of share in the first 30 seconds or so a bit about what they do with their core mission, how that relates to achieving health equity, and how they're planning to scale their solutions and their products to improve access and equity in whatever markets they might be in. So let's start off with Propeller Health, a well-known company. It's a ResMed company that's doing some really exciting work in the respiratory space. So handing it over to to Propeller Health to kick us off.
Well, both. We're now a ResMed company, but thank you, Dr. Kraft. So my name is Susa Monacelli, and Propeller Health really works in the space of asthma as well as COPD, and in asthma specifically, both across adults and pediatrics. We are able to connect devices, so essentially connect inhalers with sensors, so that not only do parents as caregivers or family members who are caring for an elderly parent have visibility on whether their family members are taking or their friends are taking their medications in a timely fashion, but they also can see the frequency in terms of adherence as it relates to also using rescue inhalers. And so as we think about kind of our mission and what we're really about is changing lives. And we connect this information now through EHRs as well as a portal for smaller physician groups. For physicians to be able to make better clinical decisions. And so by engaging your healthcare providers as well as your caregivers in this conversation, it really starts to create a surround sound for the patients. And so as we think about our conditions, unfortunately, asthma and COPD disproportionately affect disadvantaged populations. And one of the keys to our mission is to democratize care and be able to provide greater access, greater visibility, and better clinical care for patients.
Fantastic. And do you have a quick example of the impact that's making, and how do you measure that inequity?
So for us, we measure it in quite a few different ways. The first is when we look at, for example, if we start with a Medicaid population, we do a lot of work with Medicaid and Medicare populations. Our impact is really easy to measure because you can see how we reduce emergency room utilization, for example, and are able to redirect care much earlier. So part of our platform really focuses on prediction and prevention. And so we enable patients to track triggers that are very personal to them and be able to see, for example, we connect information regarding pollen count into the app, and they're able to then identify when those exacerbations can happen or when they start to exacerbate. We can predict days or weeks in advance that that's likely to happen, and be able to provide coaching and care management to those patients and prevent those emergency room visits. So it goes all the way across kind of that care continuum, but that's one example.
Perfect. Thanks. Proactive, integrated, and participatory care.
And can I add one more piece to it? I want to make it very concrete, but for us, for example, with our COPD population, we've reduced emergency room visits by over 34% with the hospitals that we work with. So that's really important and meaningful impact. It's not on a micro scale. It actually is on a macro scale for our patients.
Perfect metric, and congrats on those outcomes. Next, we're going to hear from Martha at AccendoWave.
Thank you. So AccendoWave is a pain data company. We've got 9 objective pain databases. And we can also customize pain databases for our customers. We're really focused on 2 things. One is validating your pain, so your pain is believed, and then providing pain data to improve outcomes and to improve the patient experience. And what really sets us apart is that we own the objective pain data space. Real world evidence and clinical research show that we have a pain bias problem, bias against women in pain, bias against ethnicity in pain, and bias against seniors in pain. And this is a root cause health equity problem where we need data to restore health equity and to improve trust in our healthcare system. And then in terms of scaling, we are on a data sharing platform. We use Datavant. 120 health plans use Datavant, 2,200 hospitals, most life science companies, even Google and Apple. And it's a really efficient way to transfer data in a very HIPAA compliant way. And when you're contracted on the platform, you don't have to have your own contracts. And so it's a very significant an easy way to share that data among the ecosystem.
Fantastic. And a quick question, like, how do you measure pain? What's your sort of metric there, and what kind of impacts are you seeing on both the clinical and the equity piece?
So the way that we measure pain is we correlate your brain waves with your perception of pain. And then we benchmark all of that data and have different benchmark groups. So we've got a database on women in pain and on seniors in pain and oncology in pain and MSK in pain. We measure whether or not patients think the technology got it right. And 83% of the time, the patients say, yes, you understood my pain. And right now, it's really a very subjective process with pain, and it's riddled with bias. And so we're really looking at bringing objectivity to pain, as well as a massive pain database.
Fantastic. Thanks, Martha. Up next, we have Dipak from Globo.
Thank you. Appreciate it. Name's Dipak Patel. I'm the CEO at Globo. I want to thank you for the opportunity, but most importantly, giving us the platform to talk about something we call language justice, which is essentially our belief that every individual has the right to communicate in whatever language they best understand. At Globo, we're transforming language into what we call a superpower to amplify the voices of the underrepresented. And I want to give you a quick story to bring it to life. So essentially, I'm first generation. My mom was born in India. She speaks Hindi, and she was super sick for the last 6 years. And I know that if she was provided with the same patient communication tools that we provide, she would have, 1, lived longer, and 2, had a better quality of life. And specific examples are when I'd go to the doctor with her. And I can't tell you the number of times that we would leave the doctor's office and she'd look at me saying, I don't understand what they were saying, because there was a number of times where they wouldn't have an interpreter, or the interpreter wouldn't show up on time, or maybe there was issues with whatever video interpretation device they were using. Another example is she was in the hospital many times. Every time that she got discharge instructions, it did not make sense. Not because they weren't translated in Hindi, but because they didn't really align with their cultural and religious values. I looked at the things and thought, she's not going to do half these things if you really knew her background, what she believed. She participated in a number of innovative pilots, transportation pilots, remote patient monitoring pilots. All of them turned out to be a mess, quite honestly, because, again, she and my dad just couldn't understand exactly what they're trying to do and how to do it. So I can go on and on. My mom isn't alone. 1 out of every 5 people in the U.S., basically 65 million people in this country, are either limited English proficient, they speak a language other than English at home, or they're deaf and hard of hearing, which is another population we support. And so what we do is we do 3 things. One is we enable providers with access to over 400 languages through their phone. They access a live interpreter that they can get in less than 30 seconds, some languages less than 10 seconds. Number 2 is we work with organizations through our digital app to help them not just translate, but actually tailor and localize materials based on someone's culture. And so, we'll work with hospital systems to work with a certain population to basically localize outreach materials. So people come in for their vaccines, or people come in for their mammographies. And then the third thing we do is we provide education and training so that healthcare providers understand the importance of cultural competence. They understand how to work with an interpreter. They can do fluency testing to determine whether or not they can actually speak that language. And so all this stuff is accessed via our digital product. We're the only company thinking about patient communications along the entire patient journey. And we currently support a number of hospitals and have, received a lot of really good feedback on it. So thank you.
Fantastic. And you need quick metrics on how, language and misunderstandings affects access and equity?
Yeah, there's been limited studies on it, but length of stay is about 1 to 1.5 days longer, 30% more ED visits, 40% more likely to be readmitted, 42% more imaging. There can be, though, more research done in it, but those are some of the basic facts.
Fantastic. Okay. Thank you. And those were from our best in class. Again, more advanced and longer lived companies. Next, we're shifting to a larger group, Rising Stars. These are earlier companies that are probably in some cases still iterating, but they've made it to the finalist stage, so they're doing something right, both in health equity and beyond. And first up is Yosef from Happitech. Take it away, Yosef.
Thank you, Daniel. My name is Yosef Safi Harb, and I'm the founder and CEO of Happitech. Heart disease is the #1 killer in the world, yet 80% is preventable if detected and managed. Detecting cardiac arrhythmias can be like finding a needle in a haystack. Patients spend months in and out of the hospital with multiple monitoring devices, while others cannot afford them due to health inequity. Now, what if we could solve this problem immediately today with something that 86% of the world population already has? So I left my aerospace engineering job after my father experienced this problem firsthand. And we spent 6 years with top cardiologists validating a CE marked solution that uses only the smartphone to solve this problem. And this year, we'll serve 100,000 patients across top hospitals in Europe. But there's more work to be done, especially in the US, where someone dies from cardiovascular disease every 34 seconds. And that's why we're pursuing FDA and extending our product to many more disease areas. And that's the power of Happitech, cardiac monitoring right in your pocket. Thank you.
Thanks. And a follow-up question. Can you give an example? Are you detecting atrial fib? What's your solution actually physically do?
Great. So by placing your finger on the camera, within 90 seconds, we can screen and monitor for AFib with the same sensitivity and specificity of the standard of care. And the way that it works is as your heart is pumping blood, the blood flows through your fingertips, it expands the capillaries, and the pressure changes result in tiny color changes. Now, and our camera picks up this color, and then our AI is able to make the distinction between normal rhythm, AFib, and other rhythms. And so the beauty really is that you need no additional hardware, just something you are always within a hand's and elbow's reach.
The last quick question, quick answer. How do you find that can expand access and equity to diagnosing heart disease?
Great question. So there was a recent publication from Rock Health, and it showed that less than 12% of the vulnerable population, of the population at risk of cardiovascular disease, have some access to wearable devices, like a watch or a patch or a variety of the new technologies. So that means that there's a huge population that is left out of the equation. And in addition, adding rural areas where care can be very difficult to reach, you need to take a 4-hour drive. But what everybody has is the phone. So what we've seen cases, and this is a true story, I've had one of our partners who lives in Australia. He's having dinner with his father, and he sent me a text. He says his father's not feeling well. So within 1 minute, about 6,000 kilometers in between each other, we send him the app, he installs it, and it shows up that he has an irregular heart rhythm. And so we could do that no matter where you are in the US, and you're a vulnerable population, and either your sons or your daughters have some kind of smartphone, we are able to really detect and also tie it together with the healthcare system. And that's really the power of the phone. Thank you, Daniel.
Thanks, Yosef. Okay, up next, we got Reza from PicassoMD. Take it away.
Thank you. Compelling Happitech. I'm a cardiologist by training, so big supporter, and the founder of PicassoMD. So PicassoMD, we kind of take a little bit of a different approach to population health. We fundamentally believe that you have to solve for a unit problem and scale upwards versus a top-down approach. And that unit problem that we're trying to solve is by empowering primary care providers at the point of care to make better decisions regarding specialty care and access and transition to care. So I boil that down to 2 points. One, when a patient walks into a primary care's office, whether in a rural setting or in an underserved population, they have about a 15-minute window to decide what to do with that patient. And so what we want to offer is the ability for that provider to instantly connect with a specialist across 30+ disciplines to triage the patient with a subject matter expert. So they hit a button, median time to connect last month was about 23 seconds. They get matched with a specialist, and they're able to triage the patient directly with that specialist across the multiple service lines. Fundamentally, this solves the access issue. Again, our outcomes are about an 80% reduction in emergency room visits because of the ability to triage a specialist with a specialist, and about a little over a 50% reduction in specialty referrals. And then the second aspect of what we want to offer is then, okay, great, I don't need to send this patient with Happitech enable the detection of atrial fibrillation to the emergency room. Start medication A, medication B, and then we help facilitate that referral to a local specialist. Think of it as a warm handoff, so that Dr. Kraft and Dr. Sanai can actually communicate on a thread surrounding that referral, and our back offices are connected. And the result of that, we're able to kind of get patients in a lot faster and at a much higher clip. So because of that, our access issues, we've had the great fortune of partnering with many FQHCs across the country, as well as many rural and underserved populations, and are just hoping to scale that vision.
Fantastic. And how do you guys measure equity and impacting populations that often don't get care?
So we have a whole data intelligence platform. So we actually look at provider utilization, as well as with the FQHCs themselves. So our impact is basically a several-fold higher than the average tech enablement platform, just because of the ease of use. Literally, it's hit 3 buttons on a mobile or web device and get matched in under 30 seconds. And we measure pre and post outcomes for every single unit interaction, as well as provider satisfaction. And so that's how we measure it.
Thanks. Great work. Thanks, Reza. Up next is Meena from AmplifyMD.
Perfect. Thanks, Daniel. Pleasure to be here. At AmplifyMD, we believe your zip code shouldn't determine the quality of your healthcare, and we built our revolutionary virtual care platform to solve America's specialty physician access problem. So I don't know how many of you have been in the situation where you've tried to make an appointment with a specialist or see one in the ED in an emergency situation, but today, too many Americans can't access a specialist, whether that's cardiology, neurology, psychiatry, rheumatology, you name it, in a timely manner. And that lack of specialist access and the downstream effects on patients, hospitals, and payers is costing the system over $17 billion. From a stroke patient needing to get airlifted away from their local community hospital because there's no neurologist on staff, to a cancer patient needing to drive hours away for chemo and scan interpretation because there's no oncologist in their community, to a schizophrenic teenager in the emergency room needing help and needing treatment, and there's no one there for them to go to, right? And then they're held in the ED for days on times at times. So these patients suffer when they can't access a specialist locally. So what AmplifyMD is doing, we've created our virtual care platform to provide a comprehensive solution, both from a technology perspective. So first, we're solving the problem of efficiencies, right? How do you practice medicine better and more efficiently, take away the issues with scheduling, care coordination, documentation, billing, using our AI and data-driven algorithms. Plus, we've combined that with access, built-in access to over 15 sorely needed clinical specialties across the country, so that regardless of where you are, you get the access to the care you need when you need. So with that, we're improving health outcomes, health equity, and financial results across the country for patients, providers, and health systems alike.
Fantastic. And as we know, there's lots of deserts from specialists in many parts of the country. What are the challenges you see overcoming? Is it still licensing issues state by state that would help expand your reach?
Yeah, so in terms of scaling ourselves, actually, we've been able to do it in a very systematic fashion, again, through the platform and through our medical group. We've built a team that covers all 50 states. We are able to address those healthcare deserts, as you mentioned. And for us, the biggest point of helping solve health equity is the impacts we're going to make and that we are making in terms of cutting referral wait times 80%, cutting outpatient backlogs 50%, cutting inpatient transfer rates 85%. And so hopefully our goal is to make the impact where right now the difference in death rates for an urban or underserved, a rural or underserved population to an urban population that has access to specialty care on demand is 20%. So our goal is to get that down to as close to zero as possible.
Right. Huge disparities in access. So thanks for your work at AmplifyMD. Next rising star company we're going to hear from is Duos, and over to Karl.
Excellent. I'm Karl Ulfers. I'm the co-founder and CEO of Duos. At Duos, we're focused on reimagining the future of aging by connecting older adults and their caregivers to the resources they need to age with dignity. One out of two every older adults has an unaddressed social need, things like food, transportation, home safety, etc. what we've done at Duos is we have integrated in Medicare Advantage benefits, state, federal, and VA programs, and community-based resources to directly engage with older adults along with their caregivers to then go the final mile and resolve their needs. We bring this mission to life by working directly with Medicare Advantage plans along with risk-based providers. And through these interactions, we've been able to have quite a bit of success in actually bridging the gaps that exist between older adults and the services that ultimately allow them to age with dignity.
Terrific, Karl. Can you give an example of a little scenario about how Duos makes a difference in an individual or population's life?
Yeah, we work directly with a Medicare Advantage plan as an example. And when we work with a Medicare Advantage plan, just to give you an idea about the populations that we work with, about 73% of the time, the individuals we connect with are at or below the federal poverty line. About 37% of the time, those individuals are socially isolated, which is about 2 times the national average. And about 40% of the time, they're actually food insecure. And so we directly engage with those individuals. We understand first and foremost, what are their barriers to health? Do they have transportation needs that have been unsolved? Do they have food needs that have been unsolved? And then we actually will systematically go through the benefits that they have, and then those downstream government programs and local community resources, and we actually get them connected into those services. And once we have done that, we then will go the next step, which is to actually get them connected into the preventative care that these individuals need. The rates of primary care utilization and preventative care in these populations tends to be very poor. And so once we've addressed those social needs, we then go that final mile to address those care needs. And our success rate in the Medicare Advantage plans that we've worked with, specifically on those care needs, has been at over 80% in terms of things like annual wellness visits, getting them in for preventative care screenings such as A1C tests if they have diabetes, et cetera.
Fantastic. It seems like the big issue, as we saw accelerated by the pandemic, is health inequities lead to longer term problems and
that's right,
lack of taking care of the basics. So thanks for your work. Next up, we're going to hear from the CEO of Mira, Khang Vuong.
Thank Dr. Kraft. Hey guys.
You're on.
Yeah. My name is Khang, founder and CEO of Mira. In essence, what we're trying to do is we're trying to build a Costco model in healthcare. In essence, really bring managed care to those who can't afford it, primarily individuals and small businesses without access to traditional insurance. A few really shocking statistics we have this year. The average premium for an individual plan is about $7,000, or 22% of the individual median individual house income for the US after tax. And it's expected to rise anywhere between 6 to 8% this year, the highest in a decade. About a third of the US population, or a little bit over a third, rely on Google as their main source of healthcare information instead of seeing a physician. And we also saw a very persistent decline in preventative and primary care utilization across the board post the pandemic. On the clinic side, turned out it's pretty hard to service non-insured patients. So we built a much more efficient way for them to accept the payment as a guarantee rate in exchange for a lower reimbursement. And then we pass on that saving to the patients. For members, they're getting access to about 2,000 clinics, 1,600 labs, and about 60,000 pharmacy for as little as $50 per month. To acquire a user, we built a content platform. And last year, we got roughly 3 million unique visitors across 45 states. So far, we have the number keep going up. So I have to count every day, but we have about 37,000 people sign up so far, and we're managing care for roughly 2,000 users. In 2022, we accumulated a saving about $500,000 or $227 per visit compared to the out-of-pocket rate. And one of the really cool statistics we found is because of our intelligent navigation, we allow we're trying to get user to the right type of care, and we optimize for the right provider for the most cost-efficient one. we reduced the ED utilization to about 1.57% across our population. In the future, we think that as premium continue to increase, more and more people is going to be priced out of the commercial market, where it's sort of seeing that in the past few years. So we really want to position Mira as another way, the third option for people to get care, because we think ultimately this binary of there's sort of like a binary reality in coverage. You're uninsured or you insured, there's nothing in between, and we believe there should be a third option.
Thanks, Khang. And basically, if I understand it correctly, many of your users don't have insurance at all, but through your platform, they can access a variety of services at lower costs.
Yeah, about 80% of our users do not have insurance. About 20% have insurance. It's usually a high deductible plan. Surprisingly, we have a decent amount of Canadian people signing up.
Blame it on Canada. Thanks. Great work at Mira. Up next, Pluto Health and Dr. Miles Albert. Miles.
Yeah, hi everyone. I'm Dr. Miles Baer. I'm the head of data science and informatics at Pluto Health. Pluto Health is a patient-centered smart care coordination service. We offer a tech-enabled platform that unifies patient data from across multiple sectors, including EMR data, social determinants of health data, etc. And we use that data to generate accessible, personalized recommendations for every patient on our platform. We have seen health inequity across all sectors of healthcare, and it's our goal to really empower and activate patients and help our clients empower and activate their patients to ensure that they're getting the care they need at the right time, whenever they need it.
Can you drill down a bit more on that? So, a lot of platforms have the same user interface, regardless of language, culture, education, etc. How do you use the data in Pluto's platform to meet people who and where they are?
So we integrate a range of standard clinical recommendations. Our platform's available in, or can be available in over 20 languages. All of the social determinants of health data as well, we use to adapt patient communication. We also have a very diverse staff on team of healthcare providers that give us that kind of insight as well. An example of this as well is we've done lots of work with unhoused people in California who have very disparate medical records and don't get consistent care. And we're able to unify their data no matter where they've been and give those recommendations and enable them to get the care they need, no matter what their background.
Perfect. Thanks, Miles. Next up is from the company called Power. Love the name. Lauren Vamos. Over to you, Lauren.
Hi there, guys. Sorry in advance. I was experiencing some tech issues before this, so I'm on my phone, and the irony isn't lost on me that I'm representing a clinical trial internet marketplace and can't figure out my own internet usage. But Power is, as I mentioned, a clinical trial marketplace that aims to democratize access to clinical research for all patients, regardless of their education level, location, socioeconomic status, or insurance. So we derived our inspiration initially from marketplace platforms like Airbnb. So patients can log in and they can search every recruiting trial on the internet, all pulled from clinicaltrials.gov, and filter by things like genetic marker, comorbidities, their age, their location, etc., and find all the clinical trials in the country that they may be eligible for. So the initial goal here was to democratize access for everyone by removing general barriers to clinical research. And what we found after doing that is that the numbers that we were receiving were much more representative of the actual US population than normal clinical research demographics are. So once we remove those initial barriers, we find that people of all races and ethnicities are very interested in participating in research, and that the discrepancies that we see between clinical research participation and demographic is less to do with motivation to participate in research and more to do with barriers to accessing that research. So we're removing those barriers and facilitating better clinical research access for all.
Fantastic. I just tried it out in the background. It's so much easier than clinicaltrials.gov. You're also facilitating, folks, again, who don't know they're eligible, and also now this new digital age of virtualized clinical trials. Are you helping connect those dots?
Yeah, absolutely. And what we're finding is that 44% of our patients are non-white, and that they're 3.25% 3.25 times more engaged on our website than on other clinical recruitment websites as well.
Right. I think we all know that a lot of health and medicine is driven by research results are often coming from very narrow populations. So a long way to go, but it sounds like you're doing great work there.
Thank you very much.
Our last rising star, and we're going to then riff into other Q&A, is Genie Lifesciences. And we're going to hear from Dr. Sham. Over to you.
Thank you very much. Pleasure to be here. So Genie basically focuses on two areas of inequity. Our first is rare diseases, which is in general on its own is one of the largest areas of inequity because it's not cool, it's not fashionable. A lot of people don't develop solutions or therapies for rare disease, and so they are often ignored. But on top of that, if you are an underserved population, an ethnic population, don't have means to manage healthcare, you're screwed. And so how do you now manage this? We take a tech bio approach here at Genie by creating a first-in-class therapeutic. And we do this with a platform and a mechanism, AI platform that we call Ridge. This has allowed us to take molecules from discovery all the way through clinical development to phase 2 at a fraction of the cost and an accelerated timeline. And the case study that we'll give you here is that in 2 years, we've taken a molecule from discovery, which is actively enrolling phase 2 patients for ARDS, which is the largest inflammatory cause pre-pandemic from influenza, but during COVID, basically what led to massive inequity globally because it was targeting populations which otherwise wouldn't have access to treatments for these. And so creating these first-in-class therapeutics, we hope to scale by really focusing on populations that don't have other options here and create a therapeutic option for diseases which would often be ignored.
Perfect. Are you working with repurposing generic drugs or creating your own novel ones?
No, so these are all first-in-class, best-in-class new novel compounds that are being built. And we're taking approaches by really leveraging novel clinical targets that have historically been undruggable, using the tech to create new therapies for those drugs, and then really making sure that we're targeting diseases that are focusing on vulnerable populations. And so creating a therapy or a solution where there actually is nothing.
And in our multi-omics age, we're finding almost every disease is a rare disease or it could be better subsetted. So, and last quick question, given that AI is in everything, can you give a quick example of how AI is accelerating your discovery platform?
Absolutely. I mean, I think the proof is in the pudding. I mean, a normal drug development cycle from discovery to phase 2 is about 10 years and costs about 100 million for a therapeutic. We've been able to do that for $7 million in 2 years. And so we really now are taking clinically well-validated targets, taking in-house curated data sets through a wet lab approach and a dry approach, but now using informative algorithms, computational biology and physics. This AI platform in rare disease, often the disease is very scarce. There isn't a lot published about it. There isn't a lot generated about it. And so we're able to use the simulation approach really to fill those gaps. And that's allowed us to create molecules that have showed significant efficacy, but also now helping us to deploy those in the clinical trial setting using our end-to-end approach for the populations that really wouldn't have access to these therapies at all.
Fantastic. All right. Well, thanks, Sham. Thanks to what you're doing. And thanks to all the companies for sharing your initial core mission and what you guys are doing to improve health equity and reduce disparities. So we've got about 20 minutes left and what kind of quick answers, quick questions. We don't have to do every company for every question, but just try and keep it short. I'm going to sort of ask a broad one. Raise your hands if you want to answer. What are some of the maybe surprising challenges you came up across in addressing equity challenges, and how did you address them, and what lessons might that lead for others in the space? So anyone want to jump in with the first answer there? Susan from Propeller.
So one of the things that we've learned along the way is that we've become a very app-focused digital health space. And one of our big pivots as we were dealing with individuals, especially in the Medicaid and Medicare populations, was that not everyone has phones that make it possible to engage. And even if they do have smartphones, data plans and others really prevent that engagement from happening. And so we've taken Propeller to a different level by creating an app-less experience that allows us to use SMS messaging, for example, to reach patients, as well as give them hubs that they can just put into the wall very easily, and that provides a cell plan for them, so that data is able to reach their caregiver or is able to reach their physician to help support their care. And I think that being able to meet the patients where they're at was a very critical discovery for us and has really enabled us to be more effective in reaching our populations.
Fantastic. I call it the digital determinants of health. Do you even have a phone? Do you have access to high-speed internet or any internet at all? There's lots of comms deserts as well. I think we also have Reza and then Karl. Quick answers to that question. Reza first.
Yeah, I think for us, despite providing instant access to specialists, if you want formal longitudinal care, there's often just a dearth of specialists from a brick and mortar standpoint. So actually leveraging digital point solutions that are disease specific, that can help create like a virtual kind of access solution. I think that's been something we've been working towards, but creating a centralized marketplace for all these different specialists is a really important next step. So having organizations like Amplify who can help solve a component of that is like a great value add, as well as incorporating the Time Cares of the world and Novacardis of the world, Limber Healths of the world, who can actually help with specific aspects of care. So that's been something that we've been working on and our vantage point as well.
Thanks. And I think there's opportunities amongst many of you in this cohort to collaborate together because you're offering different components, and I think we all know there'll be some consolidation in that digital health space so that platforms can be integrating some of these solutions. Brief plug, check out digital.health for all sorts of solutions. And for the companies here, please update your listings there. Next over to Karl.
Yeah, I would say there was two sort of surprising things that we've learned along the way. Well, many surprising things, to be honest, but two that definitely stick out. The first is we started as a very high touch model. And then we quickly learned that a lot of the older adults we were working with actually wanted to work with us digitally. And now over a third of our interactions actually happen digitally versus in a real high touch manner. So I'd say that's one really interesting learning for us, especially given the populations that we're working with. The second thing that I would say has been really interesting is about the needs of these populations. It has been amazing how different these populations are, but how consistent their needs are from a food, transportation, and access to care perspective. And those three themes, regardless of geography, regardless of various different socioeconomic cuts, we see very consistently as the top three needs. And that, frankly, surprised us. That is actually not what we expected when we first launched our company 3 years ago. So that consistency of those needs is really compelling to us in terms of really doubling down how we can deeply solve those challenges for people.
Great. Thanks, Karl. Over to the Miles and Yosef, then Martha. Miles.
Yeah, I think for us, it's really the complexity of health inequity and the amount of different variables that impact it. Food access, social vulnerability, all of these different things. And when you look at it from a population view, yes, those analytics are useful to see that there's health inequity there, but at the patient level, actually addressing it is very difficult. And so what we at Pluto have done is made sure we have strategic partnerships with high touch organizations, retailers like Walmart and Walgreens, that can really deliver care to patients where they are. You don't always have access to hospital systems, you don't have access to that kind of care, but there's a Walmart or a Walgreens right near you. And those partnerships really allow us to touch those patients where they are. And so it really helps reduce that inequity and activate and empower patients at the same time.
Great. Yosef, what's your Happitech learnings?
Yeah, even though you could have a device that can reach, many patients, it's worth nothing if it's not connected to healthcare. Meaning our biggest learning is focusing on patient pathways. Like, how do you collect the data generated by a device to a clinical practice so that information gets actionable and the patient is able to get treatment, next steps. So even though you have a device, but figuring out its role in the healthcare ecosystem is maybe even more important for its adoption. So that's would be from our end.
So once you get the signal that you might have AFib, what do you do next? And how do you access the cardiologist or the 1280 kg?
Yeah, where does it go? And that's why a lot of cardiologists are complaining. We just get random patients into our clinic and we don't have the data at the right time. So the data needs to be into the EHR. The data needs to be also filtered, because you don't want 1,000 ECG or AF alerts into your inbox. Like, you're already overloaded. So these are really the problems that are essentials to solve in order to really be able to create the impact in the community that you want to do.
No clinician wants more data. They want actionable insights at the right time in the right
Exactly.
Great.
Exactly.
Thanks. Over to Martha.
So two learnings, one at the patient level and one at technology. At the patient level, what we've learned is that when you don't believe my pain, I lose trust. I don't trust my doctor. I don't trust my healthcare system. And so it's a core health equity issue. Secondly, on the technology, you often hear concern about bias with machine learning, AI technology. And I would tell you that what we've learned is that we actually have the opposite problem with pain. We have one of the most subjective measures in all of medicine that both real world data and clinical research show is riddled with bias. And so what we're trying to do is really to bring objectivity with a significant amount of pain data and pain databases to the market who actually has no data on pain, and the bar on pain is really basically resting on the ground.
Yeah, it seems pain is always a painful thing to manage. And now with new ways as you develop to quantify, getting folks to appreciate that, which might be even different amongst different patient and ethnic populations. I assume genetics plays a role in pain and what drugs you might even choose to treat with. Real quick, over to Lauren and then Dipak, and then we'll ask another question. Lauren first.
Yeah, so one of the biggest challenges I think we faced early on was understanding the disparity between helping people access information about trials, which we were really good at, and then actually getting them enrolled and screened and enrolled into those trials, because a lot of people fell off the funnel really quickly when sites took maybe a longer time to respond, et cetera. So a big next step for us has been facilitating EMR integration and insurance transfer, and also just working with sites directly to make sure that they understand the different kinds of patients that they'll be receiving from Power as a portal, and just kind of trying to fit everything on one platform to make sure that we're getting as many representative patients as possible actually into the trial and not just into the site's email inbox.
Right. Getting on the list is one thing, getting through the trial is another. Awesome.
Yeah.
Dipak over at Globo.
Yeah, I think one of the biggest lessons learned is how to spin our value proposition to what's going to really resonate with the hospital. And so what I mean is, you asked me what type of metrics that we impact. I talked about reducing length of stay, reducing ER visits. There's a lot of things that impact that. And so we tell that story, but we also tell a pretty direct story to the physician to say, we can save you time, right? So normally when you try and access interpreter, you have to wait 3 or 4 minutes. With us, less than 30 seconds. You don't have to input a bunch of stuff. You can just scan the patient, right? Wristband, you get all the information. And that's just been really helpful to getting the hospitals to actually act on it, because they see direct time savings for their providers.
Great. And last word on this question over to Meena, and then we're going to hear next question coming up from Dr. Sarkar. Meena.
That's great. Thanks, Daniel. One of the biggest challenges is something you alluded to, which is the health deserts around the country, and the fact that we just don't have enough specialists around the country to meet all the need that is out there. With about 90% of the country's 6,000 hospitals having a specialist shortage of some kind, and about 30% of all hospital visits, 10% of all ED, and a vast majority of outpatient visits needing specialty access. We knew that we had to solve that problem. And so when we built the platform, it wasn't just a glorified video connection, which has been the problem with telemedicine in the past. It's a full comprehensive platform that can connect the specialists to where they need to be, but also in a way that it makes the practice of medicine more efficient. So if you have 10 doctors, can those 10 doctors see as many patients as possible in that allotted time frame? And that's how you're going to solve the health equity issue when you don't have enough resources to go around the way you would otherwise want. And how we've done that is, like I said earlier, with the platform focused on driving operational efficiencies, critical practice efficiencies, how quickly they can see a patient without cutting face time with the patient, but cutting the time with paperwork and documentation and billing and care coordination. That's what we're doing to solve that problem and the challenge that we face there.
That's what we need, more paperwork. That fourth aim, not just to get a good solution for the patient and outcomes and dollars, but to make the clinician experience better is super key. Awesome. I'm going to hand it over to Dr. Sarkar at UCSF for the next question.
Yeah, this has been really amazing to see all of these innovative new solutions. I want to ask, I heard some great outcomes from these different companies. And I also heard about some special populations. I want to ask if anyone breaks their outcomes out by these populations. For example, do you break out your data by your Medicaid populations versus your privately insured populations, or by language, or by race, ethnicity? Because it's really important to have not only inclusion, but really equity of outcomes among the people that you're serving.
Great question. Whoever wants to answer first, just jump on in.
So I love the thinking, because we could do a better job of that, especially for language, to show how did length of stay change for when we provide a Spanish interpreter to someone who speaks Spanish versus Vietnamese. So we don't do that, and I want to do that. But what we do is we provide insight to hospital systems to have them understand this is how diverse their population is. They'd be surprised to understand, wow, you have a large group of Hindi-speaking patients that are going to your dermatologist in this area. And that's where they get a bunch of really interesting insight. So we do segment it in certain ways, but not the way that you suggested.
We actually segmented a little bit differently, which is we look at the household income levels as one of the key measures, as well as then obviously geographic location and zip code, in addition to ethnicity. But just as an example, on a statistic, when we looked at Propeller and our efficacy with different populations, we actually saw a greater adherence level with patients with median household income less of 50K. And versus those above 50K. So our adherence rates went up by 9.8% for controller medications versus 8.1%. And those are the types of metrics that we're looking for, especially when we talk about access and support, but most importantly, having a meaningful impact in people's lives.
Perfect. Let's hand it over to Sham, then Miles.
Great. So at Genie, we definitely segment all of these different populations, particularly because we're going after rare diseases that are, one, not well published, two, not well documented. And so finding individuals that really need therapies and care and giving them the information to either participate in the clinical trials or even deliver and receive the therapy is definitely a challenge. And so we ended up building our own in-house AI-powered tool where we take all of the social determinants of health, really focusing on underserved populations. And I think Harb also highlighted this, that a lot of clinical trials are not diversified in terms of the clinical trial data versus real world data. And so really focusing on that real world aspect of inclusion and really focusing the delivery of the therapy to patients that really want it. And so the end product has basically been a number of algorithms that have helped us identify patients based on income, insurance, healthcare records, use of healthcare services previously, as well as execution and delivery of healthcare systems in those geographical areas, creating an overlay of the disease, the provider, and the patient. And that has really eliminated our need to work with large CROs and really changing the way that we're delivering clinical trials to get these medicines to patients.
Awesome. We've got 4 minutes left, so quick answers. Over to Miles, Lauren, Martha, Yosef, and Meena.
Yeah, we do an incredible amount of analytics across all of the different SDOH factors we have. And that's primarily because if you're meeting patients where they are, you have to be adaptable, right? Making a large sweeping change is not going to affect patients on an equitable, personalized level. So we really break that down and continually do so to make sure that we can boost every personalized recommendation for patients, no matter what their health inequities are.
Great. Thanks. Lauren, then Martha.
Yeah, so we work with sponsors and with individual clinical trial sites to help in their recruitment. And when we're presenting data to them on a weekly or bi-weekly basis, we do segmentation by race and ethnicity, as well as by a few other factors such as gender and sex, if those are important in the trial. But I do think that my personal goal in the next few months is to come up with new ways that we can segment that data, not just on a whole in terms of referrals by race and ethnicity, but we can segment that by geography, segmented by race and ethnicity, and then stage down the funnel, segmented by race and ethnicity. I think that's going to be a really crucial analytics point for us in the coming months as well.
Yeah, we need to add sociome to our metabolome and microbiome and all those other pieces, because how you define these things are cool. Martha, Yosef, and Meena, 30 seconds each.
So we have segments really driven by our customers and their needs. So our most popular databases are maternal health, seniors, oncology, MSK, the emergency department. But we can measure it other ways. We can measure the night shift versus the day shift. We can measure all of the departments across to see if you have an outlier. And customers are sometimes looking at a very micro level, like which department can I talk to because they actually have a problem, as well as understanding what this data looks like across their ecosystem in different ways, both their insured and uninsured.
Great. Thanks, Martha. Yosef?
Absolutely. So for us, most important is evidence generation for us to really be able to reach large populations. So we recently completed the 1,250 patient study where the average age was 78 years. And we had the oldest patient, it was 98, just to be able to make sure it's working across a variety of ages, but also across a variety of ethnicities. So that's for FDA, it's a requirement to be able to make sure that it's as inclusive as possible. So in our studies, we'll always target as variety of ages, variety of ethnicities, to really make sure that we can make the impact that we want to have on the health equity.
Perfect. Thanks. Meena, you've got the last word again.
Thanks, Daniel. Keeping it short and sweet. So what we do exactly that was tracking impacts by geography, by age, by gender, by specialty, kind of what everyone's alluding to in terms of figuring out what are best practices and what are the impacts we're seeing. What can we take in terms of lessons from one hospital, health system, geography, subset of patients, and how can we apply that across the board to drive even better results for entire patient population, not just one subsegment of it. So we use that to, again, reduce transfers, reduce readmissions, reduce complication rates, reduce time to treatment and length of stay on the outpatient setting similar. And the most important thing is, again, driving that time from a referral or a need for an outpatient or an inpatient specialty consult to, within minutes to hours.
Fantastic. Well, thanks to all of you for your amazing work, answering the great questions. Thanks to Dr. Sarkar. Thanks to our colleagues from McKinsey. We'll hopefully see you at the finals in Vegas in about 2 weeks. And I'm going to hand it over to our digital health hub team to close us out.
Okay. Thank you, everybody, for attending, and congratulations and good luck. You're pretty much winners at this point in our book, but we hope to see you at the grand finale. October 9th. Thank you so much, everybody.
Great. Good luck out there. Keep up the great work.
Thank you. See you in a couple weeks.
Thank you.
Bye-bye.
AccendoWave is a pain data company that measures pain, manages pain, and provides objective pain databases to do two things. One, to validate your pain so your pain is believed. And two, provide objective pain data to improve outcomes and reduce the cost of care. Listening, observing, and thinking about pain and providing objective pain data and pain databases, that's AccendoWave's superpower. We own our own distribution channel in terms of pain data and audience, and we've woven that into the fabric of our company. Pain touches all of us. 100% of us will experience pain in our lifetime. When you don't believe my pain, I lose trust. I don't trust my doctor. I don't trust my healthcare system. AccendoWave validates your pain, so your pain is believed. And we need to scale and advance companies that restore health equity and trust in our healthcare systems.
John Bertrand, Chief Executive Officer, Digital Diagnostics. Our solution, Luminex Core, was built for patients with diabetes. We detect the leading cause of blindness called diabetic retinopathy. What makes the solution really unique is we use artificial intelligence to diagnose the patient without the physician in the loop. So this means a low-skilled, high school educated operator, often in primary care or in a laboratory draw station, can run this test on a patient without a specialist being present. It's a big paradigm shift from patients needing to go to a specialist, paying an extra copay, sometimes not making it at all, to actually being able to have this as part of their standard of care when they see their primary care doctor. Our superpower is the ability to not only design, build, but validate through the FDA's stringent process these artificial intelligence algorithms that we've built. And in doing that, it's not so much the technology that's the superpower, it's our ability to get the technology into workflow and to drive superior patient outcomes. You know, technology can be great, but if we don't put it in the hands of providers in a way that impacts patients in a safe and unbiased manner, it's kind of really not that great in our opinion. It's always about the patient outcome here at Digital Diagnostics. Well, we deserve to win because we've essentially built an industry here. We were the first to be cleared by the FDA for an autonomous algorithm. We were the first to become standard of care. We were the first to receive reimbursement. And we're the first to crest over 500 clinics using an algorithm to diagnose patients, to route them to treatment, to again, drive superior patient outcome. And we're also the first in multiple studies and on multiple continents to prove that the use of this technology, again, in workflow, properly deployed, will drive superior patient outcomes, increase patient access, and do so in an unbiased and ethical manner.
Not being able to speak English or English not being your first language is a barrier in terms of your ability to understand what a physician or clinician is saying, as well as it doesn't make the lives of the clinicians easier.
Our vision for the future is one where if you walk into a health system or into your provider, your doctor's office, that you have the exact same experience as a native English speaker would have.
One of the frustrations that many clinicians face when accessing language solutions is the fact that they have to wait really long for an interpreter. Global allows you the ability to access an interpreter in less than 20 seconds. The other thing that Global does is makes the actual workflow as easy as possible.
At Global, we are passionate about making sure that health systems are able to access interpreting services in the way that's most useful to them. We should not be dictating how someone needs to access language services. There's already things in place that they're using. Let's make sure that we can meet them where they are. How do we lower that friction so that they can ultimately provide really, really great care to the patient? Being transparent and easy to use is ultimately us supporting that clinician and patient relationship.
Studies show that the length of stay at a hospital is longer for this population. They're more likely to be readmitted to the hospital. They're more likely to no-show to an appointment. There's an opportunity to elevate this underutilized superpower called language services and create a differentiated experience for their patients. Every population deserves the right to communicate with empathy, communicate in what suits them, especially in healthcare. And then we just have to make sure we invest the right type of energy to leveraging technology so that we can service these populations. And I'm very confident that we're going to make this happen over the next couple of years.
Hi, my name is Susa, and I'm the General Manager of Propeller Health, a precision digital health company that uplifts the lives of our patients and drives value to all our stakeholders. We leverage digitally connected therapeutics through an app and no app experience, surrounding the patient with coaching and support to keep them motivated in making positive behavior changes that will impact their lives. What's unique about our model is our ability to simultaneously deliver value to all our stakeholders. This is inclusive starting with the patient, the provider, the health systems, payers, life sciences, and pharmas, and PBMs. It's this unique ability to align the value that allows our solution to be truly transformative. The markets have been talking widely about the shift in value-based care for a long time, but we've not seen it widely adopted yet. With our solution, we can meet our clients where they're at, whether it's fee-for-service claims, direct pay, or value-based models. Our 10 years in clinical and commercial experience allows us to feel confident that we can drive this impact. But most importantly, none of this works without taking care of the patient first. Propeller, through creating unique signals from our sensors, supports the patient's adherence to medication plans by creating insights that enable the patient, the caregivers, and physicians to make better decisions. Physicians can access the information through our physician portal or through connected EHRs like Cerner and Epic. This takes the burden off the physicians and allows for better care for the patients. We know all of this works. We've been delivering positive outcomes for patients and health systems as well as payers and pharmas for over 10 years. And most importantly, we've been able to bring everyone together to better serve a broad, often difficult to engage patient population, democratizing access to patient care for all we serve. We're a catalyst for transforming healthcare and enabling our patients to live their best lives.
I'm Meena Mallipeddi, co-founder and CEO of AmplifyMD, the virtual care company improving access to specialist physicians nationwide. Our revolutionary virtual care platform makes our mission possible and improves health equity in two main ways. First, we make it easy for healthcare organizations to access over 15 medical specialties. No expensive carts, no complex IT builds, just a seamlessly integrated solution that works with any facility's existing workflows, no matter how big or small. And second, we make practicing virtual care easier for both the remote provider and the on-site care team. From scheduling through billing, our platform helps them practice up to 2 times more efficiently, so they spend more time on patient care and less time on administrative tasks. With AmplifyMD, more patients get access to the specialist care they need, regardless of their zip code. What's our superpower? We are the only telehealth company treating healthcare providers like the precious resource they are, with a platform that reduces their technology burden, increases their efficiency, and puts essential clinical information at their fingertips, so they can find joy in providing care again, wherever it's needed. And by doing this, AmplifyMD is making it possible for more suicidal patients to be treated in the ED by a psychiatrist, more stroke patients to be evaluated within minutes by a neurologist hundreds of miles away, and more HIV-positive inmates to be treated by an infectious disease specialist. AmplifyMD is leading the way to health equity by expanding access to specialty care in places that have historically had to do without. Across the country, our partners have seen reduced outpatient referral wait times, reduced inpatient transfer rates, reduced complications and readmission rates, and faster discharges for necessary inpatient stays. Thanks to our virtual specialty care, patients in underserved communities are seeing a neurologist in 7 days instead of 7 months. Cancer patients are having an oncologist evaluate suspicious masses without weeks of anxiously waiting, and local hospitals are helping their sickest patients recover in their home community instead of transferring them hours away.
Hello, I'm Karl Ulfers, co-founder and CEO at Duos. At Duos, we are reimagining the future of aging by connecting Medicare beneficiaries with the services that help them thrive. I was inspired to start Duos because of my family's experience navigating the aging process on behalf of my grandparents who are now in their mid-90s. Over the past decade, we have been assisting them with the basics around transportation, food, help around the home, and receiving the care that they need. This experience was very fragmented and often overwhelming and complex. By 2030, 1 out of every 5 Americans will be of retirement age, and we know that 9 out of 10 baby boomers want to be able to age in their own home. However, over half of these individuals will lack the financial resources and support to do so. We built Duos to bridge these gaps by connecting individuals to the resources and services paid for through their Medicare Advantage plans, as well as state and federal programs. We fulfill our mission by working with Medicare Advantage plans and risk-bearing providers. These organizations can either leverage our navigational platform to engage with the populations themselves, or Duos can activate these populations to solve their challenges with our unique high-tech and high-touch model. Since our launch in 2020, we've built a deep understanding and track record of being able to solve older adults' social as well as care needs. Through this experience, we have trained the artificial intelligence that powers our platform. This intelligence allows us to connect even the most challenging populations to the best resources for their unique needs by matching them to one of over 100,000 different plan benefits, community resources, and state and federal programs that we have aggregated into our platform. Through these connections, we remove social determinants of health and improve the use of preventative care, resulting in healthier, more satisfied members for the plans and the providers we work with. I'm very proud that the work at Duos is rewriting the narrative of aging. Together, let's reimagine the future of aging, where it's not just a chapter of life, but a story of joy, dignity, and fulfillment.
rare diseases present a significant challenge to patients and their families. Due to the complexity of the rare disease and the small number of patients, there are health inequities creating barriers and delays to diagnosis and limiting treatment options. Globally, there are approximately 400 million people living with a rare disease. There are 7,000 different rare diseases, out of which 95% do not have an FDA-approved treatment.
As Reza has shared, combating rare disease is one of our missions here at Genie. Our first trial in ARDS has received Fast Track designation by the FDA and is actively enrolling patients in phase 2. Using AI and ML, we're able to integrate biology, chemistry, and physics to create a robust pipeline of first-in-class compounds to treat disease that has no approved therapy. Using this platform, we've been able to map the disease, patients, and providers to better target and accelerate new medicines and figure out how to get them to the patients quickly. And those are the ones that are often most overlooked. ARDS is the acute respiratory distress syndrome, which was the leading cause of death in the last 2 years in the COVID pandemic. It was classed as a rare disease by the FDA and had no approved therapy. This recent pandemic highlighted the importance of having therapies for rare inflammatory diseases. On average, it takes 5 years just to receive a rare disease diagnosis. For people living in rural or underserved areas, this problem becomes even more pronounced. This reflects the powerful sentiment expressed by the former chairman of Merck.
Your zip code is more determinative of your health in this country than your genetic code.
Using our ML-based clinical trial site selection tool, we are able to identify underserved geographical areas, giving access to clinical trials to patients regardless of their background. We are Team Genie, changing the way to make new medicine available to all.
Detecting heart arrhythmias can be like finding a needle in a haystack. Patients are prescribed devices from 24 hours up to 30 days. But episodes can happen outside the time of monitoring. In other parts of the world, patients cannot afford them due to health inequity. What if we could solve this problem immediately today with something that 86% of the world population already has? I left my aerospace engineering job after my father experienced this problem firsthand. Found great cardiologists, and we spent 6 years developing and validating a CE-marked solution that uses only the smartphone to detect atrial fibrillation in my dad and millions of others. This year, we're serving 100,000 patients in the Netherlands, but we're not done yet, as we're expanding to a variety of cardiovascular diseases using only the smartphone. And that's our goal, to make cardiac monitoring available, just right in your pocket.
Hello, my name is Khang, founder and CEO at Mira. Our mission is to bring big health to the little guy. Nationally, there are very few options for small business and self-employed professionals to get healthcare coverage, mostly due to affordability. 30 million people are living without an affordable and reliable way to get healthcare, having to rely exclusively on care sites like the ER for very basic stuff. Our solution, the Mira membership, allowed this population to obtain preventative, urgent, and primary care as little as $50 per month. We make this happen by contracting directly with provider and create a better way for providers to serve them, with guaranteed payment and shortened revenue cycle from 120 days to as little as 5 seconds. In exchange for lower or reasonable rate, we then pass on the saving to the members. So far, we have signed up over 2,000 clinics, and we're managing members across 45 states. I know this problem very intimately, and it is my superpower because I was uninsured for many years. I came to this country as a young boy alone, and I have to manage my own finance, and I just couldn't cobble enough the fund to get my own healthcare. I want us to win this category because I want to bring more attention from investors and founders alike onto this problem. Particularly, we think that there has been so much innovation in care delivery, but there has been none in how healthcare is currently being financed. And second, we think that health equity is often equated to charity, but we think that our message is there's the real way to build a very big and financially sustainable business by pushing for healthcare equity, and we're on the way to do that. Thank you.
Good afternoon. My name is Reza Sanai. I'm a cardiologist and the co-founder of PicassoMD. PicassoMD is a mobile and web-based platform dedicated to empowering primary care providers to have improved access to specialists for both clinical decision support and referral management. With 3 clicks of a button, a primary care provider is matched with a specialist with a median time of connectivity under 30 seconds. Once connected, a simple chat-like exchange between the primary care provider and specialist, review of images, and the clinical case is completed on average in 7 or 8 minutes, with the result being an over 80% reduction in emergency room visits and 50% reduction in specialist referrals. When a referral is necessary, we create a transparent transition of care workflow, which improves visibility of the referrals and the status of the patients, both at the provider and specialist level. I think our superpower is the ability for providers to download the platform in 5 minutes and be live with specialists to improve their care. And the fact that the workflow is well within a normal patient interaction. Why I think we should be considered as a finalist and potentially winner of the Health Equity Division is that we thankfully have been able to partner with dozens of FQHCs across the nation and fundamentally improve specialist access. Previously, access to a cardiologist and neurologist would take months for a patient, and now they're being connected in seconds. And this ability to disseminate and scale, I believe, is an opportunity for us to redefine specialist access in rural and underserved populations. Thank you for considering us, and I appreciate your time.
Hi, I'm Joy Bosai, CEO of Pluto Health. I'm also a proud UCSF alum and Duke Hospital Medicine doctor. I've seen firsthand how not only mind-numbing it is to get medical records, but also how painful it can be to make sense of them. Have you ever tried to get medical records and then translate that into information? It's tough. My mom has a rare disease where many strokes happen all at once, and every time her memory fades. Doctors' names in portals are often forgotten, and even as a doctor myself, I've struggled to keep up. Until Pluto finds records nationally in minutes without the clunky processes and does so much more. We work in 3 quick steps. Step 1, we discover medical information and social determinants of health data sets in minutes. Step 2, we'll evaluate the data, and then step 3, we'll call out healthcare gaps to help fix them. We find silo data and then translate that into something meaningful. We'll coordinate care and address health gaps such as missing immunizations, preventive health screenings, and expanded access to clinical trials using community-based approaches. We're in it to support patients on their terms and at the right time. We're working with industry giants such as Walmart and Walgreens and universities such as Duke. We've raised close to $9 million, and our team and advisors are pretty phenomenal. They include the former CIO of the FDA, CEO of Medtronic, and data scientists from the DoD. Let's ditch clunky processes and expand care when it makes sense for people. Better access means better care.
Hey, this is Brandon. I'm the co-founder and co-CEO of Power. We're honored to be a quarterfinalist in the health equity category. So honored, in fact, that I'm actually filming this video on vacation in Paris in order to participate. Power is a modern clinical trial marketplace. We help people find and get access to leading medical research. You can think of our product as something like Airbnb, but for clinical trials. We've made it super easy for anyone to navigate the medical research landscape. Today, 86% of research is delayed, and the #1 reason is that they fail to find enough patients. At the same time, patients are trying to find medical researchers all the time. unfortunately, most patients just don't get access. From a health equity standpoint, this has led to a massive gap in diverse participation. Non-white patients are 8 times underrepresented in research. And this is a public health crisis because new treatments are being approved every year that aren't adequately tested for safety and efficacy in non-white populations. At Power, we believe that every patient deserves to have access to medical research. We are democratizing access for underrepresented patients. And we're incredibly proud that 40% of the patients using our platform to connect with clinical trials are not white. That's more or less representative of the US population, whereas clinical trials today only achieve 5% diversity. So what does that mean? Power is working to improve representation in research, which will mean that more underrepresented groups get access to leading medical researchers and that new, innovative treatments are appropriately tested with the right constituents every single year. Thanks.